So, good day to all. I am Jimmy Dasmariñas. I'm a community medicine doctor from the Council for Health and Development here in the Philippines, and I was assigned to answer the third question in the context of my country. So, this is a short presentation on roadblocks to universal health care in the Philippine context. I'd like to start with a quick background on how UHC was instituted in the Philippines. So in 2019, the Universal Healthcare Act or Republic Act 11223 was written into law, where one of its main promises was to make sure PhilHealth or the National Health Insurance Program covered all citizens. They wanted as many citizens to register into the system, targeting about 95 to 98% by the year 2020. But the lack of accredited infrastructure and health personnel at the grassroots level, especially in geographically disadvantaged and isolated areas, led to it only being coverage on paper and not an actual healthcare service access. In short, those citizens registered as a PhilHealth member, there is no accredited facility in their area, be it public or private. They will not have access to discounted or free services unless they seek it out in another locality with an accredited facility. With the economic crisis, especially so when the pandemic hit, this just became a symptom of the widening gap between the rich and the poor, especially in terms of the quality of health services access based on the patient's purchasing power. This is largely due to out-of-pocket expenditure covering a big chunk of the patient's health expenses. Thus, we like to describe RA 11223 as, in Tagalog, napako na pangako ng universal healthcare. Translated, nothing but empty promises, as there were no concrete manifestations of the so-called increased access, and if there were, they were barely felt. So, how did we end up here? In the UHC discourse, we tend to overlook that coverage doesn't necessarily equate to the availability of care, with the Philippines being a very good example, and governance and the overall structure of the health systems for actual service delivery plays a huge role in assuring the access to actual healthcare. So in my country, we have another Republic Act 7160, known as the Local Government Code of 1991, which led to social services, including healthcare, being delegated to the local government unit level, otherwise known as devolution. At first, this seems like a good idea as the grassroots government units have more leeway in the healthcare delivery of their locality. And in theory, they know their area better and can tailor fit health policies to their needs. But rampant corruption, poor centralized regulation and audit, not to mention politicking at a local level, are among some of the hindrances to assuring that true universal healthcare is achieved at a grassroots level. The burden of health budget allocation, infrastructure building, and health worker hiring is also delegated to the LGU. So if health is not a priority of an LGU, or if they are baseline a poorer LGU with low internal revenue allotment for health budgeting, like a fifth or sixth class municipality, they are at a baseline disadvantage. And I just like to note that usually poor LGUs only have public facilities that citizens can rely on, as they rarely have private practitioners or facilities due to the distance, like an island or an isolated valley community. So, does the umbrella really cover everyone? And if not, why? Well, in truth, poor national government support to local government units compromise local social services, which include healthcare. If you have no accredited institutions in your locality or no institutional infrastructure to accredit in the first place, or if it was accredited but you have no personnel to run it, your patients virtually have no